When we are extracting a tooth, there is a possibility of fracture of the roots or the root tip, or you might encounter a root tip on the radiograph. That's what this video is about. We are going to learn how root tips are extracted, and then we are going to learn when we can just leave them alone. So imagine you are extracting a tooth and the root of that tooth fractured. The tooth is out, but a piece of the root is still in the socket. What do you do now? You might think of getting a root tip elevator and immediately try to remove it, but that's not the ideal way to begin. So what should you do instead? Once the fracture has occurred, the patient should be repositioned in a way that you can get better visualization and adjust the light accordingly. Next, vigorously irrigate the tooth socket and apply suction with a suction tip. Sometimes if the fragment is small and loose, it will come out with irrigation alone. So always try to use the simplest technique first and then move on to the more complex ones. So once irrigation and suction are done, we should inspect the socket carefully to check if the root has been removed. We should also check the extracted tooth to see how much of the root was fractured. If the root piece is not removed with this process, we should then move on to the next technique. In order to extract such root tips from the maxilla and mandible, double-angled root tip elevators can be used because they have a sharp tip which fits easily between the root tip and the alveolar bone. We can place the narrow-angled elevator in between the alveolar bone and the root tip and push it forwards as apically as possible. Then we can try to luxate the root tip until it is moving. If this attempt is not successful, that is, if the root tip is not mobile at all, then we should place the tip of the elevator on the mesial and distal aspects of the socket until the root tip is fully mobilized. Once it's moving, removal is very easy. An instrument called root tip pick can also be used. The root tip pick is inserted into the periodontal ligament space and the root is gently teased out of the socket. But remember that it should not be used like an elevator because the tip of the instrument is very delicate. We should not apply excessive apical or lateral force. Excessive apical force could result in displacement of the root tip into the maxillary sinus, and excessive lateral force could result in the bending or fracture of the delicate end of the root tip pick. Removal of a root piece gets more challenging when it's a root tip of a maxillary or mandibular molar because there is interradicular bone involved. So we need to remove part of the interradicular bone from inside the socket with a round burr or a sharp instrument. Only then we can reach this root tip, right? We need to take special care if the root tip belongs to the palatal root because there is an increased risk of displacing the root tip into the maxillary sinus. There is another way of removing the root tip, and that is using an endodontic file. The file is first placed inside the socket and then screwed into the canal. The root tip is delivered either by hand or with a needle holder like this. Now as the needle holder is resting on the occlusal surface of these teeth, a protective gauze is placed between them. When a root tip is fractured deep in the socket and it's impossible to remove with simple luxation, then we can use the surgical techniques to remove it. So let's see the first technique. This is the root piece. To remove this, a soft tissue flap is reflected and retracted with a periosteal elevator. The buccal surface of the tooth is exposed by removing the bone here with a burr. Using a small straight elevator, the root is buccally delivered through the opening. Then the wound is irrigated and the flap is repositioned and sutured. In this technique, as you can see, the buccal bone is not preserved. But when the patient has to go for orthodontic treatment, it's very important to preserve the integrity of the buccal bone plate. So in such cases, an L-shaped incision is made, the flap is reflected and a small window is created using a round burr. The window is created corresponding to the tip of the fractured root. Then the window is enlarged so that the root is exposed and we can place a narrow angled elevator here. In this way, we can displace the root from the socket. The root can also be removed through the window if it's that small. After removal of the root, the socket is irrigated and interrupted sutures are placed. Remember that this technique is indicated immediately after the root is fractured. There could also be a scenario when the root piece was not extracted immediately, it remained in the socket for a long time and now it's covered by bone. In that case, a semilunar or a trapezoidal flap is created, a window is made corresponding to the position of the root piece, and it's removed from the window using a double angled elevator. The next technique is creation of groove on the surface of the root. This technique is used for roots that are beneath the margin of the alveolar process. First, an envelope flap is reflected and a small amount of buccal bone is removed until part of the root is exposed. A groove is then created on the surface of the root, as you can see here. This groove is now a purchase point for the elevator. We can engage the blade of the elevator in this groove and luxate the root outwards. This technique is mostly used in the mandible because in the mandible the buccal bone is dense, so it can withstand applied pressure. A groove can also be created in the bone. This is used for the roots of the posterior mandibular teeth because the buccal bone there is very dense and hard and there is the external oblique ridge. So after reflecting an envelope flap, a groove is created using a round burr between the bone and the root. The groove should make enough room so that we can place an elevator here. The blade of the T-shaped elevator or the Selden elevator is then seated in the groove and the root is luxated upwards using the external oblique ridge as a fulcrum. In the posterior maxillary area, there is a risk of the root piece going into the maxillary sinus when we try to luxate the root piece. If this happens, it's a serious complication. To prevent this, we should check the radiographs carefully before extraction and assess the closeness of the root tips to the maxillary sinus. Now, what to do if the root piece gets displaced into the maxillary sinus? First of all, the patient is informed about the situation and a new appointment is scheduled. In that appointment, removal of the root tip and closure of the oroantral communication are done in the same session. First, we should confirm the precise location of the root tip on the radiograph. Then an incision is made beginning at the canine. The incision should look like this, trapezoidal in shape, and should include the post-extraction socket. After reflection of the flap, we need to access the maxillary sinus, right? Because the root piece is in the sinus. So this is done by opening a window at the buccal bone. The mucosa of the maxillary sinus is then incised using a scalpel. Next, we have to inspect the area to find the root tip, and the root tip is removed using the suction or anatomic forceps. Now, an oroantral communication has been created here, right? So, immediately after removal of the root tip, we need to close the communication. We already have a trapezoidal flap here. We just need to lengthen it by making a horizontal incision on the periosteum at the middle and the base of the flap. By lengthening the flap, we can cover the communication and suture the flap with the palatal soft tissues. The technique of closure of an oroantral fistula is explained in detail in the video on oroantral communication, so please check that as well. Now, there are situations when leaving a root tip might be considered. The surgeon has to do a risk-benefit analysis. In some situations, the risk of removing a small root tip may be greater than the benefits. We can leave a root piece in place under three conditions. First, the root fragment should be small, usually no more than 4 to 5 millimeters in length. Second, the root must be deeply embedded in bone and not be superficial. Why? Because if it is superficial and a prosthesis is constructed over it, it will cause bone resorption and it will interfere with the prosthesis. Third, the tooth involved must not be infected and there should be no radiolucency around the root apex. If these three conditions exist, then we can consider leaving a root piece behind. Now, as we know, to leave a root piece behind, the risk of surgery must be greater than the benefit. But what is meant by high risk? The risk is considered to be greater in three conditions. First is if removal of the root will cause excessive destruction of the surrounding tissue, That is, if we need to remove a lot of bone to reach the root piece. For example, reaching a small palatal root tip of a maxillary first molar will require the removal of large amounts of bone. Second, the risk is high if removal of the root might cause trauma to important structures. For example, if the root piece is very close to the inferior alveolar nerve, in such cases there is a high risk of permanent or even prolonged temporary anesthesia of the inferior alveolar nerve. So the surgeon should seriously consider leaving the root piece in place. Finally, if attempting to remove the root tip might displace the root tip into tissue spaces or into the maxillary sinus, then the risk of removal is greater than the benefits of removal. If the preoperative radiograph shows that the bone is thin over the roots of the teeth and the separation between the teeth and maxillary sinus is small, we should consider leaving a small root fragment rather than risk displacing it into the maxillary sinus. Likewise, roots of the mandibular second and third molars can be displaced into the submandibular space when we are trying to remove them. A very important point is that if you have decided to leave a root tip in place, the patient must be informed and explained as to why the decision is better for him. In addition, the radiograph showing the presence and position of the root tip must be obtained and retained in the patient's records. The patient should be recalled for periodic follow-up visits over the next year to track the condition of this root, and he should be instructed to contact the clinic immediately if any problem arises in the area of the retained root.